Hello and welcome. I am Catherine Hargadon, Director of Programs and Events for BU Alumni Relations. Thank you for joining us for today's webinar, Football and CTE, What Do We Know and What Can We Do? I'm pleased to introduce our featured speakers. Dr. Michael Alosco is a clinical neuropsychologist and associate professor of neurology at the Boston University Chobanian and Avedisian School of Medicine, where he serves as the director of the BU Alzheimer's Disease Research Center Clinical Core. He serves as the director of neuropsychology at the Memory and Aging Clinic at Boston Medical Center. His career has been devoted to study methods to detect and diagnose neurodegenerative diseases, particularly CTE and Alzheimer's disease. His research has indeed laid the foundation for the development and validation of ways to detect and diagnose CTE during life. He hopes his work will ultimately lead to the development of strategies to treat and prevent this devastating brain disease. Dr. Alosco will be joined by Dr. Jesse Mez today. Dr. Mez is an associate professor of neurology at the Boston University Chobanian and Avedisian School of Medicine. He is the associate director of the BU Alzheimer's Disease Research Center and is an investigator in the BU Chronic Traumatic Encephalopathy CTE Center and co-leads the Framingham Heart Study Brain Aging Program Clinical Core. He joined BU's faculty in 2013, where he has been an integral player in the field of CTE and Alzheimer's disease. His research seeks to understand the genetic, neuropathological, epidemiological, and clinical aspects of Alzheimer's disease, CTE, and related dementias. He also cares for patients with Alzheimer's disease and dementias, including those at risk for CTE, in the BU Boston Medical Center Memory and Aging Clinic. Following the presentations, we will begin our Q&A session. All questions can be submitted via the Q&A button at the bottom of your screens, and we will do our best to answer as many as possible. Without further delay, I'd like to turn this over to Dr. Mez.
Great, thank you so much. So Mike and I will speak today about football and CTE. It's a what do we know? What can we do? It's a topic that is near and dear to our hearts. We spend a lot of time investigating it and seeing patients who are at risk. So I'll start with an overall introduction. I'll talk a bit about the neuropathology as well as risk factors, clinical information. And then I will turn it over to Mike, who will tell you a bit more about clinical information as well as biomarkers and more about how can we detect this disease in life and what we can do to treat it. So CTE, despite the fact that it recently has gotten a lot of attention, it is not a new disease at all. It was first described by Martlin in 1928. In JAMA. He called it punch drunk, and it was described at that point in boxers. The term chronic traumatic encephalopathy was coined by Critchley in 1949, still entirely about boxers. An important case series with neuropathological correlates was presented by Corsellis in the 70s, 1973. He carefully characterized the clinical syndrome of these boxers as well as their neuropathology. CTE really came to everyone's attention when Bennett Amalu described the first case in a football player, an NFL player, in 2005. And Dr. Ann McKee, one of Mike and my close colleagues, has really been at the forefront of describing the neuropathology in CTE. And right now, CTE, like all neurodegenerative diseases, can only definitively be diagnosed post-mortem after death. But a major goal of what we're going to talk about today and of our research more broadly is to make diagnoses in life with good certainty. So here you see the pathognomonic lesion of CTE. So this is what we see in the brain, which we see in CTE, but no other neurodegenerative disease. And it's defined by the protein tau, which accumulates around blood vessels. It's patchy. It tends to happen at the depths of the folds of the brain, of the sulci. You can see the dark staining here, which is the CTE lesions. Dr. McKee has also described a staging scheme for the neuropathology of CTE. It has 4 stages. The pathology tends to begin in the front of the brain, in the parts of the brain that are very important for problem solving and multitasking, and spreads to other parts of the brain. So other parts of the cortex, as well as later in the disease in stage 3, the memory areas, the hippocampus, and by stage 4, the pathology is widespread. The stages seem to correlate with, seem to progress over time. We see a correlation with age at death, with age, such that on average in our brain bank, those with stage 1 have a median age of 34.5, stage 2, a median age of 52, stage 3, median age of 66, and stage 4, median age of 77. When we look at the brain of an individual with CTE grossly, meaning with the naked eye, we see a pattern of general shrinkage or atrophy, particularly in the cortex. So you can see more space between the folds of the brain. These fluid-filled spaces, the ventricles, tend to be larger. The memory areas, the hippocampus, also tend to be shrunken later in the disease. And we see a separation of the septum that separates these lateral ventricles, called a cavum septum pellucidum. So one of the ways that we've really learned a lot about this disease is through the Unite Brain Bank, which has been in existence since 2008, 2009. And family members of deceased individuals with exposure to repetitive head impacts from organized sports, military service, intimate partner violence, have been donating their loved ones' brains. And we have a protocol, which I show here on the right, this parallel, it's a parallel nature of the protocol. So we have a clinical protocol and a neuropathological protocol. And Mike and I and other clinicians participate in the clinical protocol. Our neuropathology colleagues like Dr. McKee, Dr. Torstein participate in the neuropathology protocol. Each protocol is blinded. So we as a clinicians don't have any information about what the neuropathology shows while we're speaking with informants and collecting clinical information. The neuropathologists have no information about the clinical syndrome or what type of repetitive head impact exposure the brain donor may have had. More recently, we've added individuals with moderate to severe traumatic brain injury to the brain bank as well. And we've now had more than 1,300 donors participate in this process. We are really grateful for their participation. We've learned so much from them. So this is a paper where we, from 2017, where we described clinical pathological correlation among American football players with chronic traumatic encephalopathy. We at this point, we had studied 202 football players. So as you saw, as you heard from the criteria, we don't just take football players into the brain bank, but for whatever reason, the vast majority of our donors are football players. And so in this paper, we described 202 brain donors, all of whom played American football. And they had a range of exposure to football. So it ranged from youth play as their highest level of play, high school, college, semi-pro, and professional. And what we saw was with increasing level of play, there was increasing frequency of CTE, such that in the NFL players, and this was big headlines, 110 out of 111 donors had CTE. It's really important to say up front that this is not what we think the prevalence of CTE is among NFL players or among college players, even 91%. Individuals who and families who donate, they aren't required to have had symptoms in life, but individuals who donate tend to have had symptoms. Families really want to know what was going on with them. So we do think there is a selection bias that these numbers are significantly higher. But even with this selection bias, these numbers are striking and scary and suggest that this could be a major public health issue. We saw a similar relationship when we looked at CTE severity. So this is among individuals with CTE, those with severe stage 3 or 4 versus mild stage 1 and 2. And again, we saw this increasing frequency of high stage CTE with level of play. And based on that, we hypothesized that each additional year of play may increase your risk. And this was a subsequent paper. And what we found was that with each additional year of play, the odds of CTE increased by 30%. And that translates to about a doubling of odds every 2.6 additional years played. And this is a highly significant association, very unlikely to have happened by chance. And then similarly, we saw a relationship between years of play and severe CTE. So with each additional year played, the odds of developing the severe pathology increased by 14%. And from this, we tried to identify clinically meaningful cut points. How much play is safe? How much play puts you at significant risk for CTE? And what we found was that if you played fewer than 4.5 years, you are 10 times less likely to develop the disease than those who played more than 4.5 years. And similarly, if you played greater than 14.5 years, you were 10 times more likely to develop the disease compared to individuals who played fewer than 14.5 years. And the cut point for maximizing the sensitivity and specificity was 11 years. So like I said, the brain bank doesn't just have football players. We found CTE across a range of different exposures, including boxing, ice hockey, rugby, in our military veterans, most of whom also played contact sports, but not exclusively, soccer, and a host of other repetitive head impact exposures. We've just like I said, started collecting individual brains of individuals who had exposure to moderate to severe traumatic brain injury. And we have not seen nearly as high rates. And we really think that it's about these repeated blows to the head over years that's really what's driving the relationship. So just to summarize these points about risk, unlike other neurodegenerative diseases, CTE has nearly exclusively been described in the setting of head trauma, mostly these elite contact sport athletes and military veterans. And nearly 4 million Americans play contact sports annually, more than 70,000 play college football annually. So it appears that this could be a major public health issue. And what we've found is that CTE is much more closely linked with years of repetitive head impacts than with symptomatic concussion. Didn't really have time to get into the data on symptomatic concussion, but we really think it's this cumulative exposure, these hits over time, whether or not they cause symptoms at the time of impact. That's what's causing this disease. And I think I said that. So to get at how common this disease is in an unbiased sample, in an unselected sample, unlike the brain bank. We are currently conducting the Boston University football study, and this is a pilot study to assess former BU football players. It's remote, it's just filling out a questionnaire, but the idea is that we hope to eventually bring these individuals in to study them as well. We're asking about the extent of football play, history of head injuries, current cognitive, mood, and behavior symptoms. So if you are a former BU football player and you haven't participated in the study yet, we would very much appreciate your participation. You can reach out to me or to Mike, and we can provide you with the link to do the questionnaire. So moving on to the clinical presentation of CTE. This is going back to that 2017 paper where we described the football players with CTE. And we saw that the most common features in terms of behavior and mood were these symptoms of impulsivity, depression, explosivity, apathy, anxiety, hopelessness. And these were particularly common actually in the mild cases, more common than in the severe cases of, and here mild and severe again is defined by the pathology. So mild accumulation of the pathology versus more severe, stage 1 and 2 versus stages 3 and 4. Well, from a cognitive standpoint, we saw that memory symptoms and executive function symptoms, so things like problem solving, multitasking, were particularly common. And these were very common among the severe cases. And we saw that among the severe cases, dementia was also common. So having cognitive impairment such that your activities of daily living are impacted too. So 85% of those with severe CTE have dementia. And then we also saw that substance use was very common in this group, both in the mild and severe cases. Interestingly, anabolic steroids, at least by the family members' report, was uncommon. Some folks have tried to attribute the symptoms that are seen in CTE to steroid use rather than maybe the changes that are happening in the brain. So at least by the informant's report, we weren't seeing steroid use commonly. From a motor standpoint, we saw walking difficulty, gait instability as the most common feature. And then 25% of those with the severe disease were actually diagnosed with Alzheimer's in life. So CTE and Alzheimer's can look very similar. So, and it's not surprising that there could be a misdiagnosis or actually that both Alzheimer's disease and CTE are present. And we actually looked at how these different features, when we grouped them together, cognitive symptoms, behavior, mood symptoms, motor symptoms, predicted whether pathology would be present or not. And what we found was that the cognitive symptoms were very predictive of the pathology, but less so the behavior and the mood symptoms and the motor symptoms. We know that head injuries, even independent of CTE or pathological changes in the brain, are associated with mood and behavior symptoms. So it might be that it's not this neurodegenerative disease per se that's causing some of these mood and behavior symptoms, but rather the trauma itself, that other injury to the brain could be leading to these mood and behavior symptoms. But this is a really active area of research that we're looking into more. So based on some of these studies that I just described, as well as just bringing together a group of experts in the field, we proposed the traumatic encephalopathy syndrome criteria to diagnose CTE in life in 2021. And this was led by Doug Katz, also from BU, and Bob Stern at BU. And as well as individuals from experts across the country in this space. And what we the way that we define, and so the idea here is not that this syndrome necessarily is correct, and we need to do additional studies to validate these criteria before we use them in the clinic. But based on the research that we've done in the past, we thought that these criteria may be sensitive and specific for the CTE pathology. So briefly, you need to have either cognitive impairment or neurobehavioral dysregulation. This is the short fuse, the disinhibition, or both of those. There needs to be a progressive course. Another disease can't entirely describe what's going on. And then we talk about levels of certainty. How confident are we that the CTE pathology is present when we see this clinical syndrome? And we're more confident when we see cognitive symptoms because of that relationship that I described. And we're more confident when there's more exposure, so more than those 4.5 years of play, or more than those 11 years that we defined in that earlier paper. So I think with that, I'm going to turn it over to Dr. Alosco. He's going to tell you a bit more about what we're doing to diagnose CTE in life, and what we're doing in the clinic to help patients who may be suffering from this disease.
All right, thank you, Jesse. And I've been trying to answer some questions as Jesse was talking, but I've also saved some for the end as well. All right, so that was a great overview of where we stand right now. A lot of focus on kind of what does this disease, CTE, look like in people who are living? What are the signs and symptoms? And these TES criteria, as Jesse mentioned, is viewed as a major improvement to our old criteria that were developed in 2014, primarily because we think they're more specific, right? And we want criteria that are specific so that we can be confident and accurate in our diagnoses. But we're still looking at how well these work. We don't know how reliable they are. We don't know how valid they are. And importantly, we don't have that objective kind of gold standard data on people yet. And what I mean by that is a lot of the data that we have on the signs and symptoms is based on our interviews with family members as opposed to directly assessing the person. So next slide. So that's something we've been focusing on a lot. So one of the cornerstones to every memory evaluation is neuropsychological testing. So neuropsychological testing allows us to tell whether or not there's impairments in thinking and memory. So as we all get older, we all develop troubles with memory and thinking. Our job here is to identify, are those problems with thinking and memory more than we would expect for someone who's 65 years old or whatever the age might be? So we have this large study of former football players going on at our center. It's called the Diagnose CTE project, led by Dr. Stern. It recruited 120 former NFL players, 60 former college players, and then a group of people who had no history of repetitive head injury. So there's a lot to this study, but for the purposes of what I'm about to talk to you about, all of these individuals completed really comprehensive neuropsychological testing that assess all aspects of their thinking and memory. Next slide. And what we found from this analysis of this neuropsychological data is that there were the highest rates of impairment were found in the area of memory. And so specifically among the football players, 21% had impairment on tests of memory. But really what was more striking is the impairment rates on what we call long delay of words. So neuropsych testing, we read a list of words to you 3 times, you learn the words, 15 minutes goes by, we say, okay, now tell me those words again. All right, so that's really tapping into the memory centers of the brain. It's a really sensitive test to something like Alzheimer's disease. And we found almost 45% of the football players had impairments in this domain. Executive function was another domain we hypothesized might be impaired, but actually it wasn't as impaired as we commonly thought. So here is really a memory profile. And that is really challenging because that's also what we see in Alzheimer's disease. And I'm going to show you a case presentation to highlight my point here about the differences between CTE and Alzheimer's disease. So this is actually a case from our brain bank that Jesse just described. This was an 82-year-old former NFL wide receiver. He played 16 years of football starting at age 14, 9 years in the NFL. He had about 500 concussions. He retired as a construction and sales manager in his mid-60s. He developed some memory troubles with executive dysfunction, but he was still functioning quite well. For example, he was publishing novels still. But things progressed. He just started to have trouble with functioning, paying the bills, driving. And so he got a workup around 72, 74 by the neurologist and so on. He had global impairment in all domains. And then if you look at these scans here, a little bit hard to tell, and I'll talk about in a second, but he did have what we call a cavum septum pellucidum, and that's basically a tear in the tissue that separates these ventricles, these large, the large kind of black spaces there that are filled with fluid. He also had shrinkage of the entire brain, and some shrinkage of the memory centers of the brain as well, or the hippocampus. So he was clinically diagnosed with Alzheimer's disease, and he really kind of progressed to the point where he needed help in all aspects of daily living. So he came to our brain bank, like I said. We collected information on his clinical history. Can we go to the next slide? And the clinicians from our brain bank, so Jesse, myself, and some others, thought this was classic Alzheimer's disease. This is just like Alzheimer's disease presentation. We acknowledged that maybe CTE was there, given how many years of football he played. But then when the brain was examined by our team of neuropathologists, there was absolutely no Alzheimer's disease. It was all chronic traumatic encephalopathy. And so this is a case, I apologize for my dog, but this is a case, classic case of Alzheimer's disease presenting identical to CTE, but not being present. And so the only way we're really going to be able to differentiate these two diagnoses, and this is true for all of these diseases, is to be able to get a biomarker. And so a biomarker, everybody knows what a biomarker is. If you have problems with your heart, you get an EKG. It's the identical, process, but we're looking at the brain. And so a biomarker is going to allow us to detect what's going on in the brain, to detect it early. And that's what we're trying to find out for CTE. Next slide. And so we have our gold standard biomarkers. So for example, with Alzheimer's disease and with CTE, they're characterized by these abnormal proteins that Jesse talked about. Alzheimer's disease, we're very much interested whether or not there's the presence of amyloid in the brain, which are these plaques that form outside of the cells or neurons. CTE and Alzheimer's disease too, but particularly CTE, we're interested in the presence of this tau protein and its accumulation inside the cells. So we have something called PET imaging. PET imaging, you get a tracer injected into your forearm. You wait a period of time, that tracer travels, goes up into the brain. It's actually designed to stick to these different proteins. And once it sticks to it, you can actually visualize it or take pictures of it. And so there's FDA approval for amyloid PET scans since 2012, and these are our gold standard for ruling out Alzheimer's disease. There's now FDA approval for a tau tracer known as Tauvid, also for Alzheimer's disease. And other gold standard biomarkers include cerebrospinal fluid. So this is, you can actually take fluid from the spinal canal, and that fluid is also circulating in our brain. So it can provide, you can analyze it for proteins that are in the brain and provide a direct window into the brain. And then we also do MRI to get an idea of what does the structure of the brain look like. So let me walk through a couple of these so you can get a better feel for them. So here's an amyloid PET scan. So again, this is our direct measure to tell whether or not there's amyloid in the brain, or in other words, is there Alzheimer's disease in the brain? And so this is the type of image you can get. So we all have gray and white matter in our brain. And in this case, this is a negative amyloid PET scan, meaning it's not consistent with the presence of Alzheimer's disease. And I know that because you can still see gray and white matter throughout each sequence. If this were a positive scan, it would be all dark, because what that means is that tracer is being taken up and essentially occupying all of the space in the brain, and it becomes all dark. Now, we're also looking at tau PET at our center, and we're closely collaborating with the University of California, San Francisco. And we're looking, can we use tau PET to detect that pathology that Jesse was talking about in CTE? And so, for example, we can get pictures like this, where the tau tracer has traveled up into the brain, sticks to that tau protein, and we can take pictures of it. And we have some interesting studies that's showing the different utility of those different types of tau tracers. Again, these were all developed for Alzheimer's disease. So our success with them in CTE hasn't been great so far, but they do seem to have some usefulness in the setting. And we're excited to kind of report on our study known as Find CTE in the summer months here. Next slide. Yep. What I'm really excited about is, can we actually detect CTE in the blood? So all of those things I just talked about, PET scans, those are $5,000 to $10,000 out of pocket. They're not covered by insurance, so they're not accessible. They also involve getting exposure to radiation. Imagine if you can just go and get a blood draw, and you can analyze that blood, and you can say whether or not CTE or other neurodegenerative diseases are present. The data for Alzheimer's disease looks quite good, that you can analyze the blood for amyloid, for tau, and they're pretty sensitive to the presence of Alzheimer's disease. And we're working on that for CTE now, so we're quite excited about that. Next slide. Next slide. The other thing we're very much excited about is characterizing the patterns of MRI in CTE. And so in CTE, and in any kind of neurodegenerative disease, we always look at the structure of the brain to look at for patterns of shrinkage or atrophy. Actually, maybe I'll have Jesse, can you explain this study for us next while I put my dog outside?
Sure, absolutely. So in this study, we looked at our brain donors, and we requested their medical records, their MRIs, from their doctors. And we were able to accumulate a lot of scans of these individuals who passed away and had CTE. And what we saw was that there was a relationship between having CTE and having shrinkage in the part of the brain, the frontal lobe, the temporal lobe, where we see a lot of the tau accumulation and shrinkage in our brain donors as well. And then we also saw that the tau pathology that accumulated tended to correlate with the atrophy that we saw on the MRI scans. Mike, do you want to come back?
Yeah, sorry about that.
No worries at all.
Okay, so great. So what we look for is different patterns of atrophy. So what we do when we look at a brain on MRI is we essentially see, is there space in the tissue? So if you look at A and C, these are examples of brains with atrophy. B and D are healthy tissue. And I know that because in A, you can see space, right? So in between the folds of the brain, there's that black space that's not kind of hugging the skull. And in CTE, we see more shrinkage or space in the front and side parts of the temporal lobes. And then we also see more commonly a cavum, septum, pellucidum, and also hippocampal atrophy or of the memory sectors. And we didn't see that type of space in people who had normal cognition. So in summary, this really told us that maybe frontal temporal shrinkage as well as the presence of a cavum could help us with the detection of CTE during life. We are trying to better characterize the effects of repetitive head impacts on the brain through several studies at our center. This study, along with what we call the HOPE study, is still ongoing. We're really excited about these studies is because of our broad focus. We're really focusing on all types of former contact sport athletes, and we also have a really strong focus on females here. We're trying to recruit as many females who played contact sports who are over the age of 50. It's really hard to get that because of Title IX, and it just has restricted our ability to get older females who played sports. But we're trying hard, and we're looking at all types of sports, so we're excited about this study. What we're also doing is we're having increasing concentration on recruiting Black men football players. There's none who have specifically focused on this topic. And we're really having focused recruitment and studies to get these individuals into our center and to study brain aging in them. And we're really trying to address the barriers that have prevented research participation in this population in the past, where we're establishing our relationship. We're trying to educate. We spend a lot of time with our participants. We go over all of our results in detail. And we just got a great score from a grant. Dr. Robert Turner's leading it, but we are a site. And we're going to start this summer where we're going to recruit 200 Black men, 100 who played football. And we're going to do a deep dive into their brain health and look at different social determinants of health. So our research is making quite a bit of an impact, and I think the most tangible way that this is evident is through statements made by the NIH. So this NIH made a statement, and not too long ago, several months ago, where on their website it now says that chronic traumatic encephalopathy is a delayed neurodegenerative disorder that was initially identified in postmortem brains, and research to date suggests is caused in part by repetitive traumatic brain injuries. So I emphasize this cause in part because as scientists, we're always very hesitant to use that causal word. And there's always been some who have argued whether or not repetitive traumatic brain injuries caused it. But I think this statement kind of reflects how much evidence to date there is to make statements like these. And we are making a lot more advances toward being able to detect and diagnose it. And that's what we need to do so we can then move into the field of treatment and prevention. So what can we do now is the big question. We went over a lot of symptoms, a lot of different signs and symptoms. And I think people often come to us who played contact sports and they're concerned and they say, I think I have CTE. But there's a lot of these symptoms can be addressed, and if you address these, there's a lot of benefits that can be made. And that's what we focus on at the Memory and Aging Clinic that Jesse and I oversee. So we specialize in thinking and memory disorders with a focus on CTE and Alzheimer's disease, but other types of dementias. We have a multidisciplinary clinic, so it involves neurology, neuropsychology, but we also get involved. We work closely with movement disorder specialists if it's needed, as well as geriatric psychiatry if that's needed as well. We can see people on a one-time basis, or we follow them every year. If they're from out of state, we often serve as a consultation as well. And what's nice about the clinic is that it is closely linked with our research. So it also provides access to a lot of these kind of cutting edge services through research, which has been quite nice as well. And with the clinic, not only do we help with clarifying diagnosis, but we have a pretty intense therapeutic plan that we follow. So most importantly, we provide a lot of education. So there's a lot of kind of misconceptions about CTE, and we spend a lot of time going over what do we know about CTE, what do we not know about CTE. And that's true also for Alzheimer's disease as well. A lot of the people who come in have mood and behavior concerns, and often they're untreated. So we get them involved in therapy. We connect them with psychiatry, And sometimes that can result in quite a bit of benefits. With Dr. Mez, he goes over the medication list. He uses medications that he might be indicated if it helps with cognition. He tries to kind of bring down the medication list if there's too many medications that could affect your thinking and memory. And then we also rule out potential reversible causes of thinking and memory problems as well, things like low vitamin B12 or abnormal thyroid. And then we focus a lot on behavior and lifestyle changes. So sleep, I can't tell you how many people come in and they have sleep apnea and it's not being treated well. And that's a huge contributor to thinking, memory, mood, and behavior. If you take care of that, you can get benefits. If there's motor problems, we get movement involved. We make recommendations about safety for motor vehicle, living healthy lifestyles. These are all things we've all heard about, but I don't think people really truly appreciate how important exercise and diet and all that stuff plays in your thinking and memory. And we get them connected with resources like the Alzheimer's Association, the Concussion Legacy Foundation. And we also, the caregiver is often neglected in all of this, but we pay close attention to giving the resources to the caregiver so that they can take care of themselves and their loved one as well. Next slide. And with that, we just all say thank you all for being here. I apologize for my dog, but we really appreciate the time you've spent with us, and we hope we taught you a little bit about CTE, and I think we can start to answer some of these questions that are coming in now. All right, so one question, this is from Sharon. How does CTE impact military personnel? So maybe I'll let Jesse take this one.
Sure. So we know a lot about football, and we've seen these really strong relationships between the repetitive head impacts from football and and to a lesser extent other contact sports and CTE. Military gets complicated. Unlike contact sports, where the type of head impacts are relatively homogeneous, relatively similar, the types of head injury, the types of operational deployments that military personnel undergo is really mixed. So we have seen CTE in military personnel. Most of them have also played contact sports. There was a very prominent paper that came out this year reporting on CTE in the military, and all of those individuals also played contact sports. Individuals in the military really frequently play contact sports, so disentangling the two is hard. But we do think there is probably an independent component from military service and from the training and the operational deployments, but we're still in the early stages of understanding what that means.
Thanks, Jesse. Another question here from Maggie. In those that are not football players, is there any idea how many concussions impact exposures seem to be significant that lead to CTE? Second part, also, is post-concussion syndrome an indicator of later CTE?
Sure.
So, yeah, you want to take this one, Jesse?
Sure, I'll do this one too.
Good.
So, we are learning more about other sports besides football. We had an abstract presented at a meeting this year where we looked at the relationship between years of hockey and CTE, and we see relatively similar relationships. Regarding post-concussion syndrome, I think we have not seen relationships between symptomatic concussions and CTE, or prolonged symptoms after the head injury and CTE. Interestingly, we have a paper right now under review where we use helmet sensors to get a sense of, and I won't talk about it in detail, but to get a sense of how many impacts a player may have suffered over the course of their their career and how hard those impacts were. And does the force of the impact and the number of impacts affect risk for CTE? And we are seeing some relationships that not just the years of play, but how hard you're hit and how many hits seems to be related.
Cool. Great. So William, is there baseline data on prevalence or extent of CTE in brains that are not believed to have experienced significant or repeated trauma? So this is a good question. I can provide an answer. So we've only seen CTE in brains that have repetitive head impact or repetitive traumatic brain injury. We also, in some of our data and other data, for example, from the Mayo Clinic Brain Bank, have not found an association between just a single traumatic brain injury and CTE pathology. So I think that the data is overwhelming today that it's really about CTE being only present in those with repeated trauma. Do we ever see CTE in jiu-jitsu practitioners? As Jesse was saying before, we've seen CTE in fighter sports. I don't recall, or I don't have knowledge of specifically jiu-jitsu, but we've certainly seen it in kind of MMA and kind of other types of fighting sports. Then maybe for you, Jesse, how early does CTE present?
Right. So in our brain bank, we have individuals who span from 15, 16 years old all the way to 100. And we've seen CTE in individuals as young as 18. What we've learned about Alzheimer's disease is that the pathology starts to accumulate 15, 20 years before individuals have symptoms. And we think that there's probably something similar, that it's this slow accumulation of pathology over time that ultimately leads to symptoms. But we have identified it in young individuals. And we actually have a manuscript now that's focused on those young individuals that we're putting together.
All right, from Abby, how do we increase and/or test CTE and asymptomatic subconcussive hits awareness in parents of youth athletes, specifically youth tackle football players? So this is a really timely question, and I think both of us actually will have something to say about this. So, right. So the biggest question, or that we often get, is do I let my child play youth tackle football? And our constant answer is always, does it make sense to allow someone to be exposed to these repetitive traumatic brain injuries who do not fully understand the risks that come with it? And so then, as your kind of question indicates, it's up to the parents to be knowledgeable about these risks and make informed decisions. There's a lot of ways to do this, and a lot of it is through education, and Concussion Legacy Foundation has movements where they're trying to kind of essentially they're advocating for no tackle football before high school, essentially. And so they're doing a lot of education on this. Also, and I'll let Jesse speak to this, we're doing interviews with family members to get kind of their perspectives from this as well, that maybe Jesse can speak a little bit to that.
Sure. We are working right now on an ethics project closely with Christine Baugh at University of Colorado, where we are interviewing family members, or we're interviewing parents with young children across different racial and ethnic spectrums, different geographic areas, to get a sense of what they think about football, whether they would allow their children to play, what might change their opinions about play. And we're really looking forward to those results too. It's an ongoing study.
Yeah, and so another question. So I think this question was referring to our neuropsychological paper where we found memory and low rates of executive function. And the question was, how was executive function assessed? So we assessed it through structured paper and pencil tests. And to be honest, I think our current tools, our paper and pencil tools, aren't doing what we expect them to do to pick up on the types of impairments we see in this setting. So we are on the lookout for better measures, or even developing better measures to kind of capture these impairments. Maggie asked, do you only want female sports people, or do you also have use for females with repetitive head injuries who are over 50, but where injuries are not due to sports? Yes, we're interested in all types of repetitive head injuries. And in particular, we're trying to get movement going with recruiting and studying intimate partner violence, for an example. But we are interested in all sources. From William, do we expect that diagnosis of CTE in living will be limited to severe cases, or is it reasonable to believe we will be able to detect it in early stages among teenagers? This is critically important to help parents assess the risks of youth sports, especially football. This is a really good question. So I think one component of this is I immediately kind of think about our current tau PET tracers, right? Or even some of our other tau biomarkers. Our data to date suggests that they're probably best in more severe cases. And I also don't know if it's even reasonable to think that they can pick up on that really early CTE, because it is really low amount in the beginning. And in fact, even in the tracers for Alzheimer's disease, they don't pick up on it until later on. But the more that we learn about the specific signs and symptoms, if we can get better specificity with those symptoms, then maybe that would be sufficient to help with this. I don't know, Jesse, do you have anything else to add to that one?
Yeah, I do. So, it's not just about diagnosing it in the teenagers or active kids. It's mostly about predicting whether they would develop the disease later in life. And this is a neurodegenerative disease that on average affects individuals in their 50s, 60s, 70s. But we really need to intervene at the time that they're playing contact sports. So if we can provide kids, their parents, with information about how their risk changes with each additional year play. We're also conducting genetic studies to see who may be more at risk. Two individuals who play the same amount, one may be at higher risk than another. And we hope to be able to provide information, through the pediatrician or early in life about playing. I think, the best thing would be to say you shouldn't play at all. You should play a non-contact sport, and you will still get all of those same benefits. But realistically, I don't think that's going to happen. And we want people to make their own decisions and be informed about it. So I think that's sort of our approach.
So there's been a couple of questions, it looks like, about Title IX and how it's made recruitment of female athletes challenging. So I'll say, from our knowledge, Title IX, right, was started in 1972. And that was when there was equity in sports for men and women, and therefore that's when women can get more access to sports in college and other elite levels of play. So basically the situation you have is that the oldest women aren't going to be above, maybe in their early 60s now, who played when they in 1972 when the Title IX was enacted. So the situation we're running into is recruiting older females who are able to have access to playing sports at the college level. There's plenty of individuals now who are younger, but not on the older end. Is the challenge we run into.
I think it's not that Title IX hindered, it's that prior to Title IX, there were very few women playing contact sports.
Right. Let's see. Other questions? Do you have current studies on the impact of repetitive trauma for boxers? So we do follow boxers. I mean, they both in our brain bank and in our living human subject studies. We don't have studies specifically focused on them, but there is the study called Professional Fighter Study out of Vegas, where they follow all types of fighters. But yes, they are part of our research, and we're very much interested in studying them given the history of this in this population. Other questions. So some questions about protective gear to prevent concussions or CTE. You know, I think our standard response from a lot of us is that the helmets or the protective gear, yes, they might help prevent skull fractures. They might help prevent your more serious traumatic brain injuries, but they're not kind of going to prevent those injuries we're most concerned about that have been linked with CTE, or those subconcussive, where it's you're hitting your head and the brain's moving around in the skull, right? They're not going to stop your head from making that back and forth movement. Other questions? Let's see. Let's see if we've already presented. So one question, you know, we mentioned the BU football study. So Ed, you asked if we have already participated in the initial questionnaire for former BU players, what would the next step be for us? Just would like to know if there's anything else we can should. Thank you very much for asking this great question. The survey we're really excited about for reasons Jesse already talked about, but we also view it as a first step. We really want to be able to use this survey to help get access to people, to bring them in to our center to study them and get more granular data. This is just kind of our first step to see how things are, how everyone's doing, their well-being, and it'll lead to much larger studies on this. So maybe one more question for Jesse, and then I think we're going to have to end it. So maybe I'll end on this. What is the timeline for diagnosing CTE in living people? How long until it's standard procedure? I'll let you finish this off, Jesse.
Sure. So I'm optimistic here. I mean, you know, in other neurodegenerative diseases, there isn't this reluctance to make a diagnosis in life, even though we're never, you know, entirely sure. That being said, we don't want to fly by the seat of our pants. So these new criteria that we talked a bit about are being validated, right? Are being assessed for their validity right now in our brain donors. We're applying these criteria based on the information that we collect retrospectively. And we're doing it across a really big range of contact sport exposure, as well as traumatic brain injury, a host of different types of people and a host of different brain banks. And I think that if they perform well, and some of the early data suggests that they are, then we can start applying them clinically too. So I think, you know, we're not that far away. You know, in a sense, it's just a name, whether we're calling it CTE or not. Really, what Mike and I do in the clinic is address the symptoms and talk about these risk factors, and you know, it's just kind of putting a name on the syndrome that we're seeing. So I'm optimistic. I think it will be helpful to be able to have that name, but you know, I don't think actually our management will change that much in the short term. I think, you know, in what it does do is, if it's valid, then it's easier for us to conduct research in the living, and we can make the diagnosis and start to test therapies.
Thanks, Jesse. I think that is it for the webinar. I don't know if Catherine, you wanted to end it, but I'll just say thanks again to everyone for taking the time today.
Great. And on behalf of the BU Alumni Association, I just wanted to thank Dr. Alosco and Dr. Mez for sharing their work, their research, and their insight with all of us today. And also thank you to those who have joined by logging in, and we look forward to welcoming you to future BU events.
All right, thanks
Bye,
so much.
everyone.
Thank you.